Welcome to A&A Investigates, a monthly podcast featuring the latest in neurology and neuroscience brought to you by the American Neurological Association. I'm your host, Adeline Goss. In July, the World Health Organization released its updated classification of tumors of the central nervous system. An article summarizing these changes was published this month in the journal Neuro-Oncology. This set of changes reflects the increasing role of molecular biomarkers in tumor characterization, which has major implications for how we diagnose and treat patients with brain and spinal cord tumors. Joining us today to help us understand these changes is Dr. Lynne Taylor. Dr. Taylor is a professor of neurology and oncology at the University of Washington and co-director of the Alvord Brain Tumor Center at the University of Washington Medical Center. Dr. Taylor was interviewed by A&A Investigates producer and neuro-oncologist Dr. Doug Nye. Here's Doug.
Welcome, Dr. Taylor. Thank you so much for joining us on A&A Investigates to talk about the 2021 WHO classification of central nervous system tumors.
Thank you, Doug. I really appreciate being asked to talk about a subject that is near and dear to my heart.
Why is this classification system being updated now?
Well, there's been an explosive growth in our understanding of tumor biology and tumor behavior over the last 5 years. As an example, as you probably know, this is the 5th edition of the World Health Organization classification of tumors. And as I was thinking about this, I realized that the first edition was published in 1979, the most recent edition in 2016, and that previously there were between 7 and 14 years between each version. This 5 years between the 2016 version and the 2021 edition is the shortest time ever. And I think that tells us a lot about the growth in the field. This edition builds on a pre-COVID meeting in 2019 in Utrecht, the Netherlands, called the Consortium to Inform Molecular and Practical, and I want to highlight the practical part, practical approaches to CNS tumor taxonomy, which was also called C-Impact. And so because of that meeting in Utrecht in 2019, and the explosive growth, I think those are the two major reasons for the update.
Thanks for that great introduction. What are the major changes in the new classification system?
So the scope is pretty large, and I think you do have to read the paper many times to fully absorb the changes, but I would say there are several overarching themes. I think there was an attempt here to try and simplify the names of some tumors. As you and all the listeners of this podcast know, who learned about neuroanatomy, of course, we have a lot of history in the neurology field. And so they didn't completely expunge more old-fashioned terminology. So for instance, we have astrocytes and we have oligodendroglial cells, but we certainly don't have a cell type called the medulloblast, as they point out in this paper. But there's a large and long history of clinical literature about medulloblastoma, so they wisely did not try to simplify that term. Then grading is within types. So previous to this, we had anaplastic astrocytoma, WHO grade 3, and they wisely pointed out that there is no such thing, or never was such a thing, as an anaplastic astrocytoma grade 2 or grade 4. So you should know that the term in general, anaplastic tumor, has pretty much been expunged from our vocabulary at this point, and they're trying to grade within a glial tumor type or within a meningioma type, but not across tumor types. The second would be a hybrid taxonomy, by which I mean there is a melding of traditional histology with biomarkers. I would think about this as a layer cake approach, with the histology listed first and then the molecular biomarkers second, so that a diagnosis of a glioblastoma should be IDH wild type, whereas the group of IDH mutated gliomas, both astrocytic and oligodendroglial, would be in a different group. My personal favorite is then that Roman numerals have been replaced with Arabic numerals. This resonates with me because when I became a neuro-oncologist in the past, I would take clinical chart notes and replace the old Arabic numerals with the new Roman numerals. And now we're going backwards. There's a good reason for this because there was the potential to misunderstand a grade 2 or a grade 3 with Roman numerals. And so it is being replaced with Arabic numerals. And this also gives you a very convenient shorthand to be able to tell whether you're a neuropathologist or neuro-oncologist has kept up with this new classification and is changing their notes back for the use of Roman numerals. And then lastly, there's a separation now of pediatric from adult tumor types.
Thanks, Lynn. How do these changes impact our understanding of brain tumors?
I think that in the past there was a perhaps imperfect understanding that grade is what drove the biological behaviors of tumors, and perhaps even a misunderstanding on the part of neuro-oncologists that grade 3 meningiomas and grade 3 astrocytomas might somehow behave in a similar fashion. I think this really helps us step back and try to move beyond histology and understand that sometimes the more rapidly growing tumors also respond more rapidly to treatment. And it allows us to understand that grading should only be one part of this puzzle of how to help our patients understand prognostication.
What do these changes mean for patients?
I think this is an extremely exciting and important time for our patients. I like nothing better than explaining to my patients that their histologically defined glioblastoma, perhaps because it does now have an IDH mutation, can no longer really be considered a glioblastoma, and that therefore we might be able to look more optimistically towards their future. And I think it gives us a new vocabulary to help potentially reevaluate some of those old, more nihilistic views that a glioblastoma is a glioblastoma is a glioblastoma. I think that is no longer the case.
How can neurologists ensure their patients are benefiting from the molecular biomarker-based assessments for brain tumor classification?
Well, I think certainly, first of all, being aware of how complex this has become is really important. So, to the extent that you're taking care of a patient with a seizure disorder who may have had a history of a lower grade glioma, understanding that the pathology report should be extremely complex at this point. And if it isn't complex, to realize that there are probably some molecular mutations that have not been evaluated. So I think insisting on the involvement of a neuropathologist, obviously in the best of all worlds, or at least a pathologist who can confer with a neuropathologist as a second opinion or as part of a subspecialty consultation. And then just the understanding that at the very least, for the most common of our glial tumors, glioblastoma in particular, that if you don't see mutations listed on the pathology report that sound something like this: TERT promoter mutation, gain of 7, loss of 10 chromosome, EGFR mutation, or IDH mutation, that patient and family could benefit a lot from a subspecialty neuropathologic consultation.
What questions do you anticipate patients might ask about these changes?
Well, the questions, of course, that they've been asking all along and that any one of us would ask if we were a patient ourselves. The big two questions: how likely is it that my tumor will grow back and when? And how likely is it that my tumor will respond to treatment? Though this classification does not really answer those questions, I think it does give us some new tools to try and predict the answers to those questions and to have a vocabulary to use with our patients to try and help them to understand some of the limits of our abilities to prognosticate.
Why is it important for patients with brain tumors to have a neuro-oncologist or neurologist on their treatment team?
Oh, this answer could be very long. I would say that pathology is only a very small part of the puzzle. Obviously, we are all neurologists by heart, and so evaluating the neurologic signs and symptoms and combining that with the wealth of information that's available in MRI scans as part of our neurodiagnostics is key. There's a new FLAIR T2 signal mismatch on MRI that is one of my personal favorites. That's a sign of an IDH mutated tumor. There's obviously a lot about the IDH mutation in particular that might encourage more surgical resection in younger people. And the neuro-oncologist is uniquely situated to be the person who advocates for a return trip to the operating room. I think a neuro-oncologist can help reframe prognosis, particularly if someone comes from another part of the country where a lot of the care is by our colleagues in medical oncology who may not understand brain tumors in exactly the same way that you do if you have a background in neurology. Of course, the grand tradition of neuropalliative care in our field, which is treatment of headaches, cognitive changes, and epilepsy in the context of tumor-related or treatment-related changes. To that end, the very, very important role of our subspecialty at the moment, which is gratefully separating out treatment-related pseudo-progression from true tumor progression, a concept that didn't even exist when I became a neuro-oncologist, and testimony to the fact that we actually now have treatments that work so well. They can produce an inflammatory brain tumor progressive enhancing mimic on MRI scan that can be easily misunderstood as tumor progression, even by seasoned neuro-oncologists. Of course, crucial involvement in brain tumor clinical trials so we can be even better educated in the future and have better treatments for our patients and their families. I would say those are most of the good reasons why you would want to see a neuro-oncologist.
What are the most exciting directions for future research in tumors of the central nervous system?
I think this is something that you've reported on, Doug, in your article about the use of trametinib for ganglioglioma. There are some relatively rare tumor types in young people, like pleomorphic xanthroastrocytoma, PXAs, and other tumors that harbor BRAF mutations for which there are targeted therapies like trametinib and dabrafenib. I think all of us who care for younger people with brain tumors are discovering that many of them harbor these mutations for which there are targeted therapies. And while not thousands of patients, there are every day increasing numbers of case reports of younger people with even tumors that have exploded into the leptomeningeal space that are responding to some of these BRAF and MEK inhibitors that have been so useful in other tumor types, such as melanoma. I hope perhaps that some of the immunotherapies, such as CAR T cell therapies, which are chimeric re-engineered T cells, or other types of immunotherapy might be helpful in the future. Unfortunately, as you know, that has been very helpful in other solid tumor types and not as helpful in the primary central nervous system, in part because some of these immunotherapies do create a lot of treatment-related inflammatory changes, and because of increased intracranial pressure and other problems, the immunotherapy part of treatment has not been as successful to date as I hope it is in the future. Dr. Nye, I've done so much talking. I was wondering what you thought about the likelihood of updates in the future to the WHO classification and how quickly you think they're going to be in the future.
I think that, as you've alluded to, and as you have said, that changes are coming quickly. And I think there's going to be an absolute need to update these even more frequently than what we've seen in the past. These position papers that have come out between 2016 and 2021 probably aren't going to be enough to contain our deepened understanding of the molecular biology of these tumors. And so I think we'll need formal updates more frequently. What do you think, Dr. Taylor?
I completely agree with you, Dr. Nye, and I think it's a very exciting world that our patients and family members can look forward to in the future. I really think that the subspecialty of neuro-oncology is not the nihilistic subspecialty of the old days, and that we really are embarking on a future when we can just do so much more for treatment and for prognostication, and in the absence of improving survival, definitely improving quality of life.
Thank you for being with us today, Dr. Taylor. We greatly appreciate your insight.
Thank you, Doug. I really appreciate being asked to participate.
That was Dr. Lynne Taylor, Professor of Neurology and Oncology at the University of Washington, interviewed by ANA Investigates producer Dr. Doug Nye. You can find the link to the article they discussed on our website, myana.org, where you can also find past episodes and suggest an idea for a future podcast. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Drs. Megan Ritchie and Romer Giaccaden. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.